In this video, you can learn about diabetic gastroparesis, its definition, clinical features, and its treatment. Diabetic gastroparesis is an autonomic neuropathy of the gastrointestinal tract marked by delayed gastric emptying in the absence of mechanical obstruction, for example normal esophagogastroduodenoscopy. Cause of diabetic gastroparesis. Diabetic gastroparesis is a potential complication that occurs in the setting of poorly controlled diabetes, resulting from dysfunction in the coordination and function of the autonomic nervous system, neurons, and specialized pacemaker cells, interstitial cells of Cajal, ICC, of the stomach and intestine, and the smooth muscle cells of the gastrointestinal tract. Hyperglycemia, blood glucose greater than 200 mg per dl, commonly seen in poorly controlled diabetes, has been associated with diabetic gastroparesis resulting from neuropathy in the setting of chronic hyperglycemia and does not resolve with improved glycemic control. Acute hyperglycemia, on the other hand, though it can also result in delayed gastric emptying, is often reversible with improved glycemic control. Clinical manifestations of diabetic gastroparesis. Nausea is the most common symptom in gastroparesis. Other common symptoms include vomiting, early satiety, postprandial fullness, and bloating. Vomitus often contains undigested chewed food. Both weight loss and weight gain can occur. Physical examination is usually nonspecific. However, neuropathy, abdominal distension, and halitosis can present in patients with diabetic gastroparesis. Factors that may trigger an exacerbation of diabetic gastroparesis include uncontrolled blood glucose levels, medication noncompliance or intolerance, adrenal insufficiency, and infection. Treatment of diabetic gastroparesis. The first step in the treatment of symptomatic gastroparesis is often lifestyle modification. Optimal glycemic control in patients with diabetes will minimize the effects of hyperglycemia, causing delayed gastric emptying. Smaller, more frequent meals with minimizing carbonated beverages, increasing the liquid content, and reducing fats and fiber content are common recommendations. Alcohol and smoking should be discouraged, as they can worsen the symptoms. Antiemetics is often the first step in gastroparesis patients as they help with the common symptoms of nausea and vomiting. The cornerstone of pharmacologic therapy in diabetic gastroparesis consists of prokinetic agents. Metoclopramide, a 5-HT4 receptor activator, and dopamine receptor antagonist in the stomach with weak 5-HT3 receptor antagonism in the nervous system, is a commonly used medication that increases the contraction amplitude of esophageal fundic and antral musculature. It is occasionally associated with extrapyramidal side effects, for example, dystonia, and tardive dyskinesia, for example, involuntary movements. For patients with gastroparesis who cannot tolerate metoclopramide, erythromycin, a macrolide antibiotic, can be used as an alternative prokinetic agent. The prokinetic effects of erythromycin stem from the activation of the motilin receptor in the smooth muscle of the upper digestive tract, which results in coordinated peristaltic contractions that begin in the stomach and move through the entire upper digestive system, thereby propelling food into the colon. When used as an antibiotic, erythromycin can cause significant abdominal cramping, but in the setting of gastroparesis, the prokinetic effects can be leveraged to improve gastric emptying and ameliorate gastroparesis symptoms. However, the agonist effects of erythromycin diminish over time, tachyphylaxis, so it is generally used for short periods, less than 4 weeks. In refractory patients with severe symptoms, a gastrostomy tube for intermittent decompression by venting or suctioning may provide relief. For patients who cannot maintain nutrition with oral intake, placement of a feeding jejunostomy can be effective in providing nutrition, fluids, and electrolytes and reducing hospitalizations. The last resort in refractory gastroparesis is surgery, including a partial gastrectomy with Roux-en-Y gastrojejunostomy and gastric resection. Complications of diabetic gastroparesis. Malnutrition is an important complication of diabetic gastroparesis that often needs management with jejunostomy, parenteral nutrition, or surgery. Wide glycemic fluctuations can occur in diabetic gastroparesis, and this can lead to complications such as hypoglycemia and diabetic ketoacidosis or hyperosmolar hyperglycemic state. Nausea and vomiting can lead to aspiration pneumonia. Thanks for watching. Hope you enjoyed it. Don't forget to subscribe to my channel. Thank you.